Welcome back to another episode of Care Transitions Today. Our podcast targets healthcare professionals with a focus on case management and transitions of care. We're glad to have you with us today, and this podcast is being presented by the American Case Management Association. I am your host, Deb McElroy. Before we begin today, I do have a brief message from the American Case Management Association, ACMA. All of our listeners are invited to the 2021 ACMA National Conference being held June 22nd through 25th in Orlando. Engage and learn with case management and transitions of care professionals from across the country at this premier event. The conference offers a lineup of healthcare experts, and they're presenting sessions designed to improve patient care outcomes and also prepare our attendees for success in this ever-changing healthcare system. You can learn more and register at casemanagementconference.com. That's all one word, casemanagementconference.com. Today, we're continuing with our innovation theme, which we're doing in season 2, with a focus on caregiver coaching, an approach to case management for persons with dementia. This program won the most innovative poster presentation at the 2018 National ACMA Conference. And today I am delighted to welcome our guests, Wendy Martinson and Michelle Wyman from the Hartford HealthCare Center for Healthy Aging. And so welcome to both of you. I'm going to do a brief introduction and then have you give us some more information. But first, I'll welcome Wendy Martinson, who is the director for the Hartford HealthCare Center for Healthy Aging. She's a nurse of 30 years, and most of her career has focused on improving care transitions across the continuum of care and helping people remain in the community by aging safely in place. Wendy has presented and published numerous times on these topics, and she's also received many awards for her work, and we are just delighted to have her with us. I am also welcoming Michelle Wyman, who is the dementia specialist at Hartford, and she is a licensed social worker who's worked in the elder care field for more than 35 years with experience in long-term care facilities, adult health centers, home health agencies, and has worked for the states of Maine and Massachusetts in home care. Both of them have a real passion for this work and a personal connection to this work. And I'm going to now turn it over to them. And Wendy, I think I'll start with you. If you can just share your, I know you've spent so much of your career in this work and published and presented. Can you tell me about that personal connection?
Yeah, so probably it was about 5 years ago, my mom was diagnosed with dementia. It was a very shocking experience. It was not in our family before this. And what I realized very quickly with all my years of experience, I was an ICU nurse by trade, and then I had moved on to do other things in quality and to the Center for Healthy Aging. And what I found was I was very ill-equipped to manage my mom and the challenges that came along with this diagnosis. It was truly a godsend at that time. I actually just started this position, and I met my good friend here, Michelle Wyman, who really educated me and walked me through the process. You know, dementia is a very long journey with many, many ups and downs. It's a very progressive disease with lots of losses over the years. And so what may have worked today for caring for your loved one may not work tomorrow. And trying to come to terms with that. And really, one of the key things that Michelle taught me was caring for a loved one with dementia is not intuitive. You got to throw the playbook out. There's really each person with dementia brings their habits of a lifetime, their life experiences to that disease. So there's no specific black and white book that's going to be able to tell you, like there is if it's congestive heart failure, if they're putting on weight, give them an extra dose of Lasix. That's not the case here. It's really figuring out how to improve your communications, how to manage behaviors, how to prevent behaviors, and really doing that long range planning. And a key element that really sometimes goes unseen is that caregiver is the invisible patient. And you need to really work with that caregiver just as much as you're working with the person with disease. So you have that cohesive relationship and you have good quality of life. And so it really became very apparent to me that there needs to be more programs out there for people managing loved ones with dementia. And that's really where this stemmed from my line of vision.
That's great. And I thank you for sharing that, because that intersection of professional and personal, I think, is what certainly drew us to wanting to share that with our audience. And Michelle, I'll go to you because I think you obviously have had a passion for this work for so long.
I have. I think even remembering when I was a small child, I was always drawn to older people. I loved talking with them. I loved learning from them. I loved thinking about what they had gone through in their lifetime and how they have survived different things and just who they were. It was just such something I enjoyed. And then as time went on in my life, my both grandmothers and many aunts and uncles and great aunts and uncles, a quite prevalent familial history of Alzheimer's disease, predominantly older, starting around 80 or older. So that was, the brain started interesting me. What is going on here? And I happened to meet this wonderful, wonderful psychiatric nurse when I was working in Boston. I heard her speak and I was fascinated by her. And she had been working as a psychiatric nurse for years in one of the hospitals and had a mother-in-law and a father-in-law with one vascular dementia, one Alzheimer's disease, and started looking at their behaviors and realizing, as Wendy was saying, that the way we were trying to manage their care was as if they had a healthy brain. And she recognized very quickly that we need to be looking at this in a different way. So she thought of her psychiatric practice and how much she had learned and worked with communicating with people that were mentally ill, and kind of recognized how we have to look at dementia. It's not a mental illness at all. It's neurological. But that if we want to have the person feel somewhat connected to their world, we have to kind of join their reality a little bit. We have to help them. We have to look at where they're coming from. And she was like my mentor. Does a lot of work on teaching about the brain and how the brain changes with the dementia, and then how we have to, change the way we communicate and respond, looking at the environment, looking at a variety of things. And so this wonderful nurse, was the mentor that got me really fascinated. And so since then, and I always worked in an environment where there were elders, a nursing home or an adult day care center, or senior citizens, in the community that were ill. And many of them had a cognitive, dementia diagnoses. So it just became more and more fascinating. And then as Wendy said, I really took on the role of wanting to empower care partners, families and care partners, to learn what it was about, to learn how to look at it in such a way that it wasn't this negative, terrible, thing, so that we could still enjoy the relationship with the person with the disease that you loved so much, but things were changing. So that kind of took me in that direction. And that's how I kind of got going with my coaching and looking at families and working with families.
So Wendy, can you give me a little history on your program and the center? How long have you been operational?
Sure. The Center for Healthy Aging has actually been in existence for 16 years. It started with resource coordination and continued to develop over the years. But in 2014, we received a good-sized grant from the Department of Social Services with the goal of trying to keep people aging in the community and out of skilled nursing facilities, trying to connect them and educate them on how to stay at home. And so with that, one of the deliverables was developing a chronic disease management program. And I was hired specifically to implement the deliverables. And as we were looking at it, it seemed at the time everyone was developing disease management programs on heart failure and COPD and your typical long-term care illnesses. And as we all know, we're aging society and there's more people being diagnosed with dementia year over year. And I was aware of the struggles that I was having with my mother. And it just seemed that maybe we should invest these grant dollars into creating a dementia specialist program. And as the stars aligned, Michelle Wyman's was moving here from Massachusetts, and her resume came across the desk. And another colleague of hers that has a large volume of dementia experience also applied. So it just seemed like the perfect opportunity to start with these two brilliant women in the field of dementia and put together a program specifically for caregivers caring for loved ones with dementia.
That's great. And I understand even today, so in 2021, it's fairly unique
Yes.
to your knowledge. Is that right?
Yes. Yeah, there's not a lot of people really doing what we do. A lot of people just don't focus on the cognitive disorders, the dementia program, the dementia needs.
That's great. Well, thank you for sharing that history.
As Wendy was saying, dementia programming and assistance and is very, very important. Because of the aging population of our world, we are in this country, we're seeing more and more dementia. In the world, 1 every 3 seconds, one person every 3 seconds is being diagnosed. And in the United States, 1 person every 63 seconds is being diagnosed with Alzheimer's disease or a related dementia. So as you can imagine, the numbers are expanding, and we are having to deal with this illness and understand this illness. And there hasn't been a lot of resources or a lot of understanding in the past.
So that highlights exactly why we have you here today sharing your knowledge. Thank you for that background.
You're welcome.
So I thank you both. I'm interested, Michelle. I think there is, certainly our podcast reaches our colleagues in case management and transitions of care, but I can imagine healthcare professionals have families, and much like Wendy described, there'll be people listening with interest. So I guess I would ask if you could describe some of the initial signs and symptoms of dementia. Let's start from the basics that, should be referred to a physician. At one point, are you referring to a physician for a definitive diagnosis?
Sure. I think the first thing we need to recognize is that memory loss and cognitive changes that impact day-to-day life are not normal aging. Years ago, everybody was diagnosed senile dementia or hardening of the arteries, and we kind of assumed it was just what happens as you aged. We know that's not true because there are many, many, many centenarians and very old people that live beautiful, healthy, cognitively, the brains are great. So some of the things that families or people could start noticing in the initial stages, like a little subtle short-term memory changes, kind of forgetting some recent events, looking like a little bit more confused, being a little bit repetitive, seeming not as attentive, kind of have a reduced concentration. They kind of, don't seem to be grasping the whole picture, and it may come and go a little bit in the beginning. Changes in mood, too, is another big issue. A lot of times people with dementia, with a dementing illness, actually become very apathetic. They kind of lose all interest in things that they always enjoyed, and they kind of disengage, and families will think, are they depressed? What's gone on here? What's happened? That apathy is very common, and we don't really know what to do with it. Sometimes we can't, the change in the mood seems very, what's going on? Difficulty completing some different normal tasks. Sometimes all of a sudden it seems difficult to figure out, paying the bills, or a few little things that, she was always a great cook and now it seems like she's having a hard time doing that. So those kind of subtle changes occur. And then we find that as time goes on, you find it happening a little bit more. Memory loss is very, especially the short-term memory loss. People think that's dementia and everybody has memory loss in the beginning, which is not true. Some people have just a personality change. Some people have communication issues, having a hard time finding the words, getting the words out. They seem a little bit withdrawn or apathetic, as I said, and that's their start of it. So I think when families see a change in a loved one, or a coworker sees a change in one of their coworkers, thinking, what could be going on? And the reason why it's really important to do this at an earlier rather than later stage is because there are treatable conditions. There are things that medically could be causing a person to have some changes in their memory, have some cognitive difficulties that could be treated and things are fine. And so I think a lot of times we're worried and we kind of will attribute it, oh, she's very stressed, or she's overtired, or she's getting older, or she's worried about, whatever it might be. And so we poo-poo it, we kind of can rationalize it. So the more we try to get the word out that there are many treatable things, it could be medication related, thyroid, could be electrolyte imbalances, B12, it could be a variety of things. If we can identify what's going on, and the only way to get that done is to have a physician talk to a doctor and let them know you're having some concerns, what they may be. So I think there's a lot of stigma still attached to having a neurocognitive disorder or a dementia, which we want to take away because it's not helping us to treat the disease and get people to the doctors early enough.
So that's really something that should be empowering, right? And
Right.
As you were talking, or as I was thinking about it, I think we all have some personal experience with family members. I'm thinking of going to see a primary care physician first, but for our case management colleagues that are listening and those in transitions of care, they may be encountering a family who was in an acute care setting or something like that for a different reason, for a medical reason. So anything that you could, are there any questions that they could ask, or something that would prompt them to be aware that in their plan of care, they need to be thinking about this?
Well, one thing I can think of is a lot of times when a person's medically ill and in the hospital, they may have what's called acute encephalopathy, a delirium. And so they may have this mental status changes, because of the change in environment, the illness, their age, et cetera. So many times I think when a care manager is working with a patient and their family and who's got this going on, kind of delving a little deeper with the family. What goes on at home? How, what do you see at home? Are there any, memory changes? Are there any personality changes? Because I think it's hard to know, especially the environment of the hospital can be overwhelming for the elder anyhow. And if there are some of these concerns, to really be, identifying the importance of speaking to their physician and trying to get them to get a referral for a little bit more of a neurocognitive assessment, a memory screen, and then some. Because I think, especially in acute care setting, it's hard to truly say, is this the environment? Is this the physical illness?
Right.
Or is this a true dementia? So I think trying to look at some of the history and pointing out some of the things that might be a little concerning, or that the family may be telling you that have you ever really thought that this could be a little bit more, and you could see a specialist to determine, what's going on.
Okay, that makes sense. And just as I'm thinking about, the quality of life of that person at home, with your experience, anything that you would, and again, I'm thinking we might have a couple of audiences here. We have our case management professionals, but we also have people with that personal investment. So anything that...
Yeah. I think that, quality of life is, defined differently by each of us. And some people may think if a person has a dementia, oh, they have no quality of life, which is the farthest thing from the truth. Many people do very well for a very long time, and what they might need for encouragement to kind of stay independent, helping them to stay independent, providing opportunities for choices that kind of support their individuality, who they are, because nobody wants to become dependent. But they don't need to become dependent. Sometimes we may have to put different strategies into play to help them remain independent. But that's something that we can do on the outside. Encouraging social interaction, maintaining relationships that they've had. As I mentioned, this apathy and this kind of pulling in a little bit, becoming less confident, I would say, because they've got this memory loss or they're feeling a little confused in their world that they're living in. We need to help them to, continue with their relationships and their social interactions. Providing meaningful activities. If they always like to go to the theater, let's keep doing that. Their friends knew they did that, or they can still participate. They love to go out to dinner or whatever it might be, bike riding or hiking, or, keeping those activities going and offer opportunities for that, which will provide a better quality of life. The other thing is physical activity. We cannot say enough about how important it is for all of us, dementia or not, to maintain our functional abilities as we age. We got to keep moving. We've got to stay active physically. This not only helps functionally, but it also promotes better mood. And it can slow down the decline of the disease. So that's something, taking a walk doing anything that they like to do that's active is really beneficial. And then we talk a lot about offering cognitive stimulation. There's opportunities galore to take in a lecture, to learn a new card game, to go out and learn, there's all kinds of, now in this world, a lot of virtual programs, that continue to stimulate us, that we're interested in, to learn new things. That provides a lot of good function, helps to keep the function of the brain going longer as well. I think also, thinking about good nutrition. There's a lot of healthy nutrition is important, paying attention to those things. I think the person with dementia, because they tend to be a little bit less maybe secure in who they are with the changes, might need a little help with these things. But I think keeping a sense of humor, sharing fun times and laughter with those, that just kind of looking at that person as this disease is just one part of them, their essence, their soul, their interests haven't really changed, because, so we want to remember that. Things that do help people with this disease is a daily routine, helping establish a daily routine, reducing some of the daily frustrations that may be hard for a person with this disease by using visual cues, putting, out tasks if they want to, putting out things so they can see it, to do it for themselves. If they have a hard time, organizing clothing for the day, having that out and visual, or their breakfast, having the cereal and the milk and the banana or whatever out, so that they can continue to do it instead of have to figure out where things are. I think when we are caring for somebody or helping to care for somebody with this disease, we really have to slow down. Presenting a positive environment is slowing down in the care that we provide, really get down to that living in the moment where that person is at. We forget, because we don't see the brain, that this is an illness, and that they take more time to process information. They take a little bit longer to kind of do what they need to do. So if we can slow down and provide a positive environment, they're going to have a better quality of life. And I think that if there are, they want to communicate, they want to share their feelings, or they want to talk, we got to be good listeners. Oftentimes they may show some of their sadness, frustration, anger, and instead of us trying to poo-poo it and say, it'll be okay, I'm here, or don't worry about it, that doesn't feel like you're heard. So instead, saying, it sounds like, you're having a hard day, I'm here for you, or I can understand why you'd feel frustrated. right now. So kind of, looking at that validation of feelings and listening. The communication becomes harder for a person with this disease. And sometimes if we're rushing and not paying attention, we're just trying to fix it, which it can't be fixed. And it doesn't allow that person to feel as heard. And I think two other things. One is like, if there is a behavior challenge, they're upset about something, they couldn't get the words out, they're frustrated because they're having a hard time doing something, they've misplaced something, they've lost it. We know how frustrated we feel if we lose our keys or we can't find something. Think about that. So providing more of a positive response to those behavior challenges, whether it be just let me help you look, or just trying to be quiet and be reassuring. And also the other thing is, time goes on with a person with this disease. Sometimes, we forget that if they have a hard time identifying that they're uncomfortable or they have some pain, that we kind of poo-poo it because they're not telling us. Maybe they can't identify it. Maybe they don't recognize it as being, but so we kind of monitoring discomfort or pain issues as the disease progresses is also something that helps to provide a better quality of life for the person with the disease.
So those are, I think, invaluable tips, and I appreciate that. I'm going to shift us to sort of the case management perspective for those professionals whose role it is to get them where they can maximize their life and their independence, as you're describing, Michelle. So, Wendy, can you talk a little bit about options for long-term case management for folks with dementia?
Sure. So when we're talking about long-term case management, I feel like there's sort of two arms, right? There's the arm that tends to be pulled in with the accountable care organizations that are out there, where there's case managers associated with the primary care practices that are constantly reaching out to those high-risk individuals. So usually it's people that are using the healthcare system quite frequently. And you do get assigned a case manager, and that is free as being part of the accountable care organization. And that can do it can help with the long process, the long journey of dementia, right? A lot of this, though, falls on the families to pay out of pocket. So there's geriatric care manager organizations that literally will come and they'll pick the loved one up, bring them to their doctor's appointment, keep all the physicians in the loop of what's happening, communicate with the family, pick up the medications, fill their pill boxes. But this is fairly costly, depending on where you live, it can be anywhere from $100 to $200 an hour for something like this. So you are paying out of pocket. If you have a long-term care insurance policy, sometimes they will pick up the coverage for this, or at least some of it. So if you're working with someone who does have a long-term care policy, reviewing what the policy says with them, because there may be a section in there for case management. They may call it just case management, care management, geriatric case management, or you can even reach out and call the 1-800 number for the long-term care organization. There's also a little bit more economical private care management organizations. Some of them actually also coexist and manage some of the Medicaid patients. And I'm thinking specifically of an organization that we have in Connecticut, where they manage a lot of our Medicaid population, but they also have a fee-for-service arm that other individuals can hire them to do. They're a little bit more hands-off than the geriatric care manager, where the geriatric care manager is more like a surrogate family member. This is definitely, the private care management is not somebody who's going to be bringing them to the doctor's office, but it's going to be checking in and making sure that you are able to get to your doctor's appointments, you're able to pick up your prescriptions and those types of things. So, and then depending on what state you live in, there may be services available. Again, through your Medicaid department, you may need to even access them through your protective services of the elderly organization. Here in Connecticut, we have the Connecticut Home Care Program for Elders, which helps eligible clients continue living at home with really a deeply subsidized care and services. And it's my understanding that most states offer something like this. So it is, I think, one of the key things, whether you're doing this from a professional standpoint or from a personal standpoint, is knowing to do a lot of research. A lot of these programs are hidden. And if you don't know about them, or you don't know to ask the right person, or you don't have an organization like ours to come to ask these questions, you're going to be hunting and pecking around and not even being aware of a lot of resources out there. And as a case manager, and really what we've done with our dementia specialist program is making sure that we keep abreast of any type of program that's out there, whether it's free or a fee for service. But you do need to educate yourself on it and do a lot of research in that perspective.
So you were talking about, those are some options for long-term care. And you started our discussion today saying, each person is unique and the needs are unique. But just, thinking about Medicare or Medicaid, you just referenced, or private health insurance, I know that so much of this burden often does fall to the families, but any other tips or information that you would share that you can think of to help guide, our case management and transition of care folks, to help guide families?
Sure. So I think there's the case management piece and also the understanding of the families, and somehow in the middle we have to meet. And so when I'm saying that, a lot of the families are under the impression that Medicare pays for everything. And it's usually the case manager's job to educate them that that's not true. And it also sometimes then puts us in an uncomfortable position. We can always remind individuals that Medicare, we know, covers your acute care hospitalizations, your doctor's appointments, even the appointments with the specialist. So maybe you're seeing a geriatrician, a neurologist, a primary care. So maybe it's even saying to them, these are the things that it does cover for you to have care. And if you have a skilled need, you can go to a skilled nursing facility. But if you're just going to a skilled nursing facility because you can't manage the individual at home, then you have that uncomfortable conversation. The public thinks that they're just going to pay for skilled nursing home. They also think it's just going to pay for home care, not understanding that there is this medical need and that everything is based on the medical necessity. So making sure that we educate families on that. There are some Medicare Advantage plans out there that will pay for private duty services, not all of them, but it's calling the 1-800 number, the customer service, and finding out if this is a paid benefit for them. And sometimes it'll pay for a CNA maybe a couple times a week, or a personal care attendant. And that may be the only thing that someone needs at that particular time, because they just may need help bathing or washing or preparing meals. Certainly as they age, as the disease progresses, those will change, but there are little things like that that maybe would be covered under a specific Advantage plan. But before you sign up for the Advantage plan, you want to make sure you know what they do cover. Straight Medicare, unfortunately, doesn't cover private duty services. There are some, so if the individual has dementia and they're still working, there are some private payers that will also cover private duty services. But it's a lot of times it's asking for that certificate of coverage and reading through the certificate of coverage for your insurance plan and finding out what that is. Sometimes there will be some durable medical equipment needs, which is covered. And then there's other things like your electronic pill boxes or your emergency response system. In Connecticut, if you're on Medicaid, some of those things are covered under Medicaid, but they're not covered under Medicare. And sometimes the long-term, if you have the benefit of working with someone who has a long-term care policy, some of those long-term care policies will cover some of the extras, will cover caregivers, may cover some of that extra equipment that you need at home. But it's all like the person with dementia, their payer source is also very individualized.
And there's the challenge, right? There is the challenge. Well, thank you for that recap. Both of you mentioned, I think at the beginning, we're talking about the person who has dementia, and I think you referred to the caregivers as the other patient. And just how can families support the caregiver that's in place wherever they are located, and what can caregivers do for themselves?
I do think that caregivers or care partners of somebody, a loved one with dementia, sometimes have a hard time letting go. And they feel that it's their ultimate responsibility, especially if it's a spousal relationship, that they've got to take care of this person, and they will, almost put themselves in an early grave by not asking for help. So I think what we as case managers, professionals, as well as families, wanting to help their family, their mother or their father or whoever it might be, their sister or brother taking care of an aunt or whatever. We need to educate them about what this disease is all about, how the dementia progresses, how as time goes on, the person may be physically doing very well, but needs a 24-hour supervision because they may not be able to get help if they were in an emergency situation. They may decide to they may leave a stove on. They may go out of the home thinking they'll take a walk and they could become lost. So that's when the burdens start becoming overwhelming, when you can't leave home unless that person has somebody with them or is with you. Then as time progresses a little further, not only do we need that 24-hour supervision, but now we start having to be physically assisting the person with their ADLs, with their personal care needs. And the care partner, that's the new word, more or less, the care partner, it has taken over all the IADLs already, and now it's taking over all the ADLs. So for some people, that's really difficult. If you've had if the traditional married couple and the wife always did all the housekeeping, laundry, cooking, grocery shopping, now it's the husband that has to do all that. It's an added burden, and it's an added challenge, and it does make him feel overwhelmed. So if we can help the family members understand what would be beneficial, learn about the disease, stay in touch, call, visit, send a card, be there, offers emotional support, validate the caregiver's efforts. That is something that many times the person with dementia can't say, thank you, I know this is hard for you, or you're so good to me, thank you. As time goes on, they may not realize or able to do that. So if we on the outside as family members can say, boy, Mom, you love Dad so much. I can really tell by the way you're caring for him. This is hard, and I appreciate it, or whatever. Just validate their efforts. Helping with errands or meal prep or grocery shopping or transportation, if that's something that's needed. Not expecting the caregiver to call you and say, can you go to the grocery store for me? Just calling up and say, I'm going to the grocery store. Can I get you a few things? Would you need milk or eggs or whatever? I'd like to bring, some things over. The big thing is, people will say, let me know if you need something. And it doesn't work that way because oftentimes, the caregiver, as I said, doesn't even reach out for help. So they may not. It's better if the person in the family says, Mom, I'm coming over to take Dad out for the afternoon and I'd like you to do something fun for yourself. Or Dad, I'm coming over to stay with Mom and I want you to just, relax or do whatever. Adult children, if they can work together as a family, we know that every child in the family has a different relationship with the family members. So depending on who's ill in the family and how that relationship has been, there are some times when it's not going to be then the person's not going to be able to do the hands-on or be as present. However, they could do something long distance, by paying some bills for them or sending in a home-cooked meal from a restaurant once in a while, or those kinds of things. I think that if adult children, there's more than one in the family, if they could get together, sometimes we try to recommend, put a little schedule together so that it's not burdened on just one adult child, which a lot of times we hear happens. So, who's going to be doing what for the person with the dementia? encouraging the caregiver, really to understand that if self-care is needed. And if they don't take care of themselves, they're not going to be around for the person that they love and that they're responsible for caring for. It's really important that we continue to say that always to caregivers, helping them to encourage them, helping them to see that their needs are important. Oftentimes they say they feel very guilty if they do something for themselves. And we try to work on that and say that's not the case at all. This is a lot. This is hard work. It's important that you give to yourself so that you can be healthy to be doing what you want to do for your loved one.
Do that self-care, right?
Self-care, exactly. And I think that sometimes caregivers, will choose to forget their own medical appointments. They won't go to their mammograms or their colonoscopies or their doctor's appointments. And then they can get themselves in a sick, and not because they just feel they don't have the time, they don't have anyone to stay with their loved one, whatever it may be. So it's just so important that all professionals as well as family members really recognize, as Wendy said earlier, the care partner really is the second or the invisible patient. We've got to support that person. Helping find resources. Sometimes it's hard, as Wendy mentioned. We don't know what's available. We never had to go looking for in-home care or for what do I need to do here and how do I do it. So I think the professionals, that's a point in time when we can help them by identifying what's available in the area that we live in, what kind of financial resources, what kind of community supports, what kind of volunteer programs, whatever it might be that they need. And the biggest thing is to kind of identify, having the person that's providing the care, the caregiver, say, what's your biggest challenge? What do you find hardest to manage here? And trying to go from where that person is at by providing the support.
So I know that you just mentioned the word resource, and so I want to pick up on that because I believe that your organization has put together a guide or a resource, correct?
Yes, we have.
Yeah. So can you talk a little bit about that?
I will. So we put together a care partner resource, a dementia care partner resource guide that truly is very, we put it through the health literacy guidelines, so it's very easy to read. And this is predominantly to help the person understand what dementia is, how it progresses, best ways to communicate, and see, it really has a lot of good information, safety issues, community resource information, handling some of the challenging behaviors, learning how to communicate differently. So it's a real pragmatic, practical guide with strategies and tips. And it does it pretty, I think people have found it very easy to read and have found it to be quite helpful, whether it be professionals that, are working sometimes with people with dementia, as well as family care partners.
So if our listeners wanted to get a copy of that, they can contact ACMA, or would they contact you directly?
So they can either contact the Hartford HealthCare Center for Healthy Aging. We'd be happy to share it with the American Case Management Association. We have electronic versions, we have print versions, depending on, it seems like depending on where you are in age, you either like the book print or you prefer the electronic. So we do offer both. But they can Google us at Hartford HealthCare Center for Healthy Aging. When our webpage would come up, you click on dementia support, and then, which is on the upper left-hand side of the page. And then you can just click download Dementia Care Partner Guide. We have it there in English and Spanish.
That's great, because Michelle, you've given some very practical tips, throughout our conversation today, and Wendy, you did as well. So I'm thinking that might be of interest. I know we have a little bit more limited time before we're done, but I'm curious to, if you have an example of how your organization has supported a patient or family through their journey.
Yes, I can talk about a family I've been working with for probably 4 years now. And initially it started off with a son and his wife coming into the Center for Healthy Aging, worried about mom. and dad, but mom was starting to show some memory loss and some personality changes, and dad was kind of poo-pooing it and not saying she's fine, and they didn't know how to talk to their father to say, I think we need more. We need more support here. We need to look and see if something's going on with mom. So that was the initial. So we got them on their track, got them to see a geriatrician, get a referral from the primary to the geriatrician. Sure enough, mom was diagnosed with Alzheimer's disease. And then the journey began. As soon as she received the diagnoses, the son who had reached out to us, and his wife, and brought dad in, and dad always wanted to bring mom. So for the first 2.5 years that I worked with them, the husband would come in with his wife, who had been diagnosed with Alzheimer's disease and was really wanting to talk about things. And we had to, that's a different kind of a session, because you want to be respectful of the person who's has this disease, as well as provide some support and encouragement and some practical tips and understanding for the husband. So we did that for a couple of years. And I kept working on him because he was giving up his tennis playing and his golf, which wasn't very often, but maybe once a week, depending on the winter or the summer, that wasn't healthy. So it took a long time to kind of get him to understand that she would be absolutely fine with a companion, or maybe look at a day program. So gradually, as time went on, he hired a companion, and he did return to his active sport once a week, which was really beneficial for his mental health, stress level, et cetera. Then he decided, she was having more and more shadowing him more and always behind him at home, and that was getting hard, that he would consider looking at a day program. We got him into an adult day program that she truly started really enjoying. And so now he's got 2 days to himself, which felt really good. And, now she's very advanced in her dementia, and he has care practically 4 days a week, helping him up to get her up and dressed and bathed. She goes to daycare a few days a week. He's got some help and some support pretty much every day of the week. And he was so opposed to that, because he was thinking about his wife, who she had been, and how this wouldn't be something she would have liked, he thought. And, we went through times with him when he was really sad, because some of her friends were they kind of dropped her. They didn't call as much anymore. She didn't want to go out and meet them for lunch, even though he would accommodate that, bring her, because she herself was feeling a little bit self-conscious and didn't want to do it. So he had a lot of struggles, because they were a social couple. They had a lot of great friends. She was also a big golfer and skier, and things changed, so the grief process, all those losses that he experienced, he would call and we would talk through it, and he'd get it off his chest. And then I would, kind of try to encourage him to really learn a few different ways. One funny example was that she went through a time when she wasn't recognizing him. So she would say to him, late in the afternoon, early evening, more the sundowning time, "What did you do with my husband? Where's my husband?" And of course, he would be very, "I'm your husband. I've been married. I am," and she didn't believe a thing. So 2 or 3 times she called 911 and the police came, because he was trying to explain to her and reason with her, "What are you talking about?" So I had to kind of help him understand that at that moment, she didn't recognize him as her husband. Many times people with this disease live in the past. And I suggested an approach which works, but he was hesitant to try it. The approach was that he would, when she came in and said, "Who are you and why are you here? What did you do with my Paul?" Her husband's name was Paul. Go say, "Oh, he had to run to the store. Let me go out and see if he's back." Remove himself, even for 5 minutes. I said, "Go in the garage. When you come back in from the garage, say her name before approaching her," because sometimes they understand, they hear the language, they hear it in the voice, and, "Oh, that's my familiar person," even if the face looks different. So he tried it and it worked. And so we kind of got him to recognize that she couldn't understand reasoning and explaining. She was very distraught and felt the need to call the police. So it worked out, so he checks in periodically, sent me a note recently, an email, just wanting to update you on my wife. And he's done such tremendous, growth in understanding the disease, learning how to just be present with her, not feel so, stressed and that he has to manage it all, because nobody can. It's not a one person's job, especially as the disease progresses. So he's been a wonderful, it's been a wonderful journey with him. And his sons have called me. They've just been so happy as well. So it takes a village. Takes a village sometimes, not only the family, but the professionals.
Your resources and your expertise and your experience really wraps around that patient and caregiver and family, and it makes a difference. So
Yes.
that was a great example. Thank you for sharing that.
Oh, you're welcome.
As we're wrapping up our time together, I'm just curious, maybe personal reflection from each of you to share with our listeners. I mean, you've both done this work for a long, long time, and but experienced, as you shared at the beginning, some personal impact from this disease. So, you've shared so much wisdom here, but just from a personal space, anything you would want to say to someone embarking on this journey?
Yeah, I just feel so emotional at times at how difficult it can be. I think that it's not only, it is a grief process, and it's kind of a circular grief process, trying to accept that the person that you love is changing. And as I said before, not seeing the brain, it's hard to understand the disease and see the implications of the disease. Some families have so many trials and tribulations and challenges in trying to manage the person with this disease that I really, really, really are always trying to empower and let them know how important how they show their love in so many ways that they didn't even know they could do it. There was a gentleman once, he was in his 90s. I worked up in Boston, and he loved his wife, and she was very advanced, couldn't talk, oddly, she loved to sit at her kitchen table, and her whole life she loved watching the birds. They had a beautiful backyard with trees and bird feeders. And this gentleman was pretty elderly, and he was kind of off balance, and the son came and said, "Dad, you have got to stop getting a ladder out and putting a seed in those bird feeders. You're going to hurt yourself." And he said to his son, "I will not stop. This is the only way I can show my love to your mother, because she so enjoyed the birds." And so that's the heart of a caregiver. And it's poignant to watch. And it's a very, I feel blessed every day to have the opportunity to support some of these wonderful people and to show them just, sometimes when a person with this disease passes on, I just say, it's been such a long struggle that it's a blessing, because it's hard, and it's not, it's just not we don't easily understand it. So that's my story.
Thank you for that.
Being a nurse now for over 30 years, you really see the way care has advanced. When I was in nursing school, we were told you reorient the person with dementia. You bring them to your reality. And as Michelle mentioned early on, you have to join your reality. You need to be able to build that relationship with the individual and really enjoy those moments of joy, because there still are moments of joy. For me, on a personal level, I think the biggest challenge for me, again, as Michelle had mentioned, was grieving. You are grieving a person who's living, and you're grieving that loss every single day. It's your relationship has changed. What you're doing I was doing for my mom is not something you would expect to do as a daughter. And as the disease advances, you're taking on more and more responsibilities. And I was lucky I had a sister and brother who shared some of those responsibilities with me, but some people don't have that, and they don't have that support. And what truly was a godsend for me was meeting Michelle and her and the other dementia specialist colleagues, because you really don't know how to care for this person with dementia, and you need people to bounce ideas and give you suggestions, because these are the types of things, it doesn't come to the forefront of your mind. It's very complex to care for the individuals with dementia, and you really need a strong support system and to be identified as, as the caregiver, your needs do go out the window. No matter how much we talk to the caregivers about, you need to take care of yourself. And Michelle said it took the gentleman 2.5 to 3 years to finally say, okay, I'll give you an inch and I'll try this. And some, what's the person with dementia is definitely going through a hard time, but so is the caregiver, and being patient with them and recognizing that they are a vital member of the team, of the care team, when you're planning the care for that individual. They need to be able to do what the plan is. And they're going to be able to tell you, like, that's not going to work, or that is going to work. So making sure that you are bringing the caregiver, the family into it, but really supporting that caregiver. And, I think that's been probably one of the best things that has come out of our program, was the development of the dementia specialist service line.
You can see so clearly the value of that role. And I applaud both of you for the work that you're doing. Not easy work professionally, and I know our colleagues will be grateful for the information today. As we wrap up here, I just again want to extend my thanks to both of you. Any final comments before we wrap?
Just thank you for the opportunity to talk about this. We hear a lot about a lot of other chronic conditions. We don't hear a lot about dementia. It's not at the forefront of everyone's mind, but we are living in an aging society, and the number of people with dementia are increasing day after day after day. And we really do need to put best practices and research into play for this diagnosis.
Well, thank you. And with that, thank you, Michelle Wyman, and thank you, Wendy Martinson, for joining us today, for sharing your experience and wisdom. Join thousands of your peers who have made the decision to leverage the connections, learning, and knowledge afforded through ACMA membership. Available exclusively to ACMA members is the Member Education Center, where you can access a multitude of recorded webinars, CEs, and peer-reviewed articles, all 24/7. Visit www.acmaweb.org/membership to learn more about this resource and other benefits. For our listeners, we would love to hear your thoughts about today's episode. Please leave us a rating and a written review. Also, let us know what other topics that you want to hear about, so we know what is going to be meaningful for you. Don't forget to subscribe to Care Transitions Today so that you can be notified when we upload new episodes. And please stay tuned for the next episode as we continue our series on innovation. You could hear this innovative program making such a difference professionally and personally. And we're going to continue to try to bring you that information. And with that, I wish you a good day.